So,
Perfect.
all right, everybody, thanks for joining us this afternoon. We've got Dr. Ashley Hardin coming to us from UT Southwestern, and she's going to pick up on the talk on pulmonary hypertension that we had started just a couple weeks ago. So, Ashley, thanks so much, and please take it away.
Awesome. Well, thanks everybody for joining, and whoever ends up watching us on YouTube a little bit later. I'm happy to always stop me if anyone has a question throughout the talk, and then everybody can always feel free to email me or contact me, and I'm happy to walk through some of these concepts in a little more detail. There's a good amount of information that I want to cover, so I'm glad everybody has access to the recording and can come back and actually take a look at some of the slides, because I'll fly through some of them, but there's a lot of juicy details in some of the slides. So Dr. Jakubowski a couple of weeks ago started our lecture series on pulmonary hypertension. I'm gonna move it forward and talk a little bit more in more detail about hemodynamics and how we manage pulmonary hypertension, and then treatment strategies as well. Are included, of course, in the management. We're going to focus here really on groups 1, 2, and 4. I'm not going to spend a whole lot of time talking about groups 3 and 5, 5 being multifactorial mechanisms of pulmonary hypertension and disease states and conditions associated with group 5 PH that we don't really understand exactly their mechanism of the development of PH. And then group 3, intrinsic, really lung diseases and sleep apnea, OSA, OHS. There aren't really medications that are, frankly, approved for the management of those diseases, with the exception of ILD, interstitial lung disease. And if patients with interstitial lung disease have an elevated pulmonary vascular resistance, there's now an approval for Tyvaso or inhaled treprostinil in order to help their quality of life and improve their walk distance. But we're going to really focus on group 1, where we have a lot of our tools. We'll talk about group 2, of course, as it pertains to a lot of us in advanced heart failure and transplant. And then certainly we'll talk about CTEPH at the end. Okay, so here's what we're going to review today. I'll remind everybody about the updated definition of pulmonary hypertension. We're going to talk about the role of right heart catheterization and how to define whether a patient is vasoreactive or not if they're confirmed to have pulmonary hypertension. We'll kind of put all this together in a case that'll allow for a framework for discussion about group 1 PAH and the updated treatment recommendations that came out from the 7th World Symposium on Pulmonary Hypertension that was last summer. This includes a focus on risk stratification and then goals of risk stratification and treatment. And then we'll move on to group 2, pulmonary hypertension in the setting of left heart disease, and circle back to the role of vasoreactivity testing in this patient population. We'll touch on group 4, CTEPH, and then I'll circle back. Actually, after each of these sections, there are key takeaway points. Okay, so let's get started. Reminder of the hemodynamic definition of pulmonary hypertension. This is actually from the updated. So the World Symposium on Pulmonary Hypertension happened last year. It was in Barcelona, if I remember correctly. And there are really nice, relatively short summaries of each recommendations from each group. So group 1, PAH, group 2, groups 3, etc. So this actually came from one of the updated documents that was published in the European Respiratory Journal. So remember, pH is just an umbrella term. Your mean PA pressure is greater than 20. If you have pre-capillary pulmonary hypertension, basically pulmonary arterial hypertension, you have a mean PA pressure that's greater than 20, but your wedge pressure is less than or equal to 15. And your PVR, the cutoff actually has been reduced from 3 to 2. So your PVR needs to be higher than 2. If you have isolated post-capillary pulmonary hypertension, you of course meet criteria for pH, mean PA greater than 20, but your wedge is greater than 15, and your PVR is low, less than or equal to 2. Combined pre and post capillary pulmonary hypertension, which we see in a lot of our heart failure patients, whether with HFrEF or HFpEF, mean PA pressure greater than 20, their wedge is elevated, and so is their PVR. And then briefly, we're not going to talk about this in detail. It could be a whole talk on its own, but exercise-induced PH or uncovering left-sided pulmonary hypertension, your mean PA pressure over your cardiac output, the slope of that ratio of greater than 3 millimeters mercury per liter per minute between rest and exercise is suggestive of exercise-induced pulmonary hypertension. Okay, in general, when to proceed to right heart cath and what do the guidelines actually say? If a patient has a significantly elevated pulmonary artery systolic pressure or right ventricular systolic pressure on echo, they should proceed to a right heart cath to define their hemodynamics. Right heart cath's important because we need to confirm the diagnosis of PH, and also it can be prognostic based on some of the hemodynamic measures that we get. If somebody has persistent symptoms despite medical therapy, especially our heart failure patients, it'll be helpful to guide treatment. And then we need it in patients who are undergoing evaluation for orthotopic heart transplant in order to assess their pulmonary pressures, make sure it's safe for them to move forward with heart transplant. And then vasodilator testing, if they have substantial pH, we'll talk about that, becomes important and prognostic in this patient population. Again, the right heart cath, we obviously can measure a wedge pressure. If we can't get a wedge pressure, it's recommended to try and obtain a left ventricular end diastolic pressure, establish again and confirm the diagnosis, establish severity and prognosis, and then vasodilator therapy testing. So basically, catheterization is required for essentially every patient with suspected pulmonary hypertension. Vasoreactivity. So really, historically, vasoreactivity testing has been done in a specific population of patients with pulmonary hypertension. And those are patients who have pre-capillary, really idiopathic PAH. The definition of a responder is a patient who has a fall in their mean pulmonary artery pressure of at least 10 millimeters mercury to a mean PA pressure of less than 40 millimeters of mercury. So a drop in 10 to a mean value of less than 40 without a significant change or an increase in the cardiac output. And then calcium channel blocker therapy has been recommended in this patient population. I'll show you the next two slides will show you data surrounding that recommendation, and it'll show you why a lot of centers will do just vasodilator testing in any patient with PH who has an elevated mean pulmonary artery pressure, but the data is not for calcium channel blocker use longer term is not what it is in patients who essentially have kind of idiopathic or hereditary and drug and toxin associated pulmonary hypertension. Okay, so here's the effect of high dose calcium channel blocker on survival in patients who have primary pulmonary hypertension or that pulmonary arterial hypertension, really idiopathic for the most part. Those who are responders or have a positive vasoreactivity test versus those who do not. So those who had a positive vasoreactivity test are here in green, and their survival was significantly better with calcium channel blocker use than those who were not vasoreactive in this patient population. Now, it turns out that effect of calcium channel blocker can persist for a period of time, but it doesn't always sustain long term. And these patients need to be followed over time. And the addition of pulmonary phosphodiesterase inhibitors and endothelin receptor antagonists, other pH therapies may be warranted in the future, but they tend to have a different prognosis up front in response to calcium channel blockers. And then if you look at, in our cath lab, at least everybody's first heart cath where they don't have a markedly elevated wedge pressure and they have some degree of pulmonary hypertension, so that our cath lab physicians don't have to look and make the assessment of what kind of pH that patient has. They tend to get vasodilator testing with, generally here with inhaled nitric oxide. But if you look at the long-term responses to calcium channel blockers in patients who have non-idiopathic PH, we can look here. This is interesting. Let's look at the second down, appetite suppressants, so kind of fen-phen use. And those patients who have acute vasodilator responses here in the yellow dashed line, they actually maintain a long-term calcium channel blocker response. It's really, now we know, an idiopathic and probably drug and toxin associated pulmonary hypertension. If we look at those who have connective tissue disease, the third down on the y-axis, even those who had this acute vasodilator response in the cath lab, long-term, their calcium channel blocker response was not sustained. So really in that patient population, there's not much of a difference with long-term calcium channel blocker use. POPH is portopulmonary hypertension, another type of group 1 PH, and those who tend to have maybe an acute vasodilator response, it's not a whole lot of them that are responders, and they don't tend to have a long-term calcium channel blocker response. And that's similar for HIV, congenital heart disease, and then pulmonary veno-occlusive disease or pulmonary capillary hemangiomatosis. So again, these are all types of group 1 pulmonary hypertension, but it's not every patient in group 1 PH who's going to have this survival benefit. So really we say idiopathic, drug and toxin associated, who really need a vasodilator test and then would benefit from long-term calcium channel blocker use. Okay, so moving on to a case. Now that we know a little bit about vasoreactivity testing, we can interpret the data I'm going to present here. We're gonna take this case, kind of keep it in mind as we go through the next several slides. We have a 45-year-old woman who presents with dyspnea. Here's her echocardiogram, of course, here on the right-hand side, and you can see that she's got a dilated right atrium and right ventricle. Her RVSP was reported at greater than 80, so that's pretty high. Her hemodynamics, her right atrial pressure was a little elevated at 9. Her PA was 97/42 with a mean of 65, quite elevated. Her wedge pressure was 11, and her cardiac output, at least by thermodilution method of assessment, was 5.7. It gave her a cardiac index of about 2.9. So her pulmonary vascular resistance came out to 9.4 Wood units. She had a vasoreactive test done that was negative. She was not a responder. We did a 6-minute walk test where she walked 350 meters. She tells us her symptoms, and we assess that she's functional class 2, which is consistent for the most part with her 6-minute walk distance. Her NT-proBNP is elevated at 564. She has a relatively normal hemoglobin and creatinine. So she's ultimately diagnosed with idiopathic PH. So let's stop here because on your boards there will be group 1 PH questions. This is where we have a whole lot of our data. We have new drugs that are coming out to treat this, or at least Sotatercept is kind of the hot topic with the group 1 PH patients currently. So how do I decide which drugs to use for this patient and why? And we're going to talk about why you should take a risk-based approach. So this is really the updated treatment algorithm that was recommended by the task force at the World Symposium for PH this past July and was published, I think, in September. So sorry, I didn't update this reference citation. It's not currently in press. It's actually published. So you can take a look. It was Dr. Chen and group. And we're going to go through each part of this over the next few slides. So really therapy for group 1 PH, we're talking about idiopathic, hereditary, drug and toxin associated PH, and connective tissue disease associated PH. So in these patients, you're going to do an initial risk assessment. And based on what their risk is, you're going to either deem them high risk or not high risk. And that's really your first treatment algorithm decision. And then you're going to actually reassess their risk 3 to 4 months after they've started treatment. You're going to reclassify them, and that's going to help you determine what their short-term prognosis is and how to change, or whether you need to change or not, their medical therapy at that point in time. Okay, so again, the patients we're going to talk about are those who do not have significant vasoreactivity upon testing. So those patients, the data that influenced the guidelines here, it was still based on patients that had a mean PA pressure for the most part for the trials that tested patients. Their mean PA pressure did not necessarily include the new definition of pulmonary hypertension. It was still involved patients largely with a mean PA pressure greater than or equal to 25 and a PVR that was greater than 3. So this is the patient population we really have data for. And they had phenotypically clear-cut group 1 PH. As we all know in practice, this often is not the case. You have patients who are messy. They have lots of comorbidities. So we'll take those into account. And actually the published task force updated guidelines really tell you kind of what to do in terms of patients with lots of different comorbidities. So this is clean cut, what's probably going to be on your boards, et cetera. So step 1, the initial risk assessment. We'll talk about how do we calculate initial risk in the next couple of slides. So, but let's say we do an initial risk assessment, and we want to take this risk-based, goal-oriented approach. The goal overall is to achieve and maintain a low-risk status. So we have lots of different risk scores that we can use. All the validated risk scores that we have include functional class, 6-minute walk distance, and cardiac biomarkers, BNP or NT-proBNP. These have clearly and consistently been the strongest predictors of risk. Not all the risk scores actually take into account hemodynamics or imaging of the right ventricle on cardiac imaging, cardiac MRI or echo, but some do, in particular ESC and ERS, initial risk calculator or follow-up risk calculator. So basically, you're going to calculate the risk, but you also want to factor in hemodynamics and RV imaging into your clinical decision making. So for example, I use initially the ESC, ERS, really comprehensive initial risk assessment. And then in our group, in our clinic here, we do follow-up risk stratification with the Reveal Light 2 risk calculator, which takes into account really blood pressure, heart rate, renal function, cardiac biomarker, 6-minute walk distance, functional class. That's it. But the initial one will include right atrial pressure, cardiac index, if a patient has a CPET, have they had a history of syncope, et cetera. So it's pretty comprehensive initially. So you can actually go to this website here at the bottom right, www.pahinitiative.com, and there's a whole, you can click on these, say you're a healthcare provider, and it pulls up the risk calculator. So there are a variety to choose from. Again, I use the 2022 initial ESC/ERS guideline calculator when I first see a patient. And for follow-up, we use the Reveal Lite 2 calculator, which just has six different variables. Okay, so that's step one. We calculate a risk. Now we have step two. We've decided whether our patient is not high risk or they're high risk. If they are not high risk, which is lower intermediate risk, the patient then gets started on dual upfront oral combination therapy, which is a PDE5 inhibitor, ideally tadalafil, and an endothelin receptor antagonist. If they are high risk, they're going to start on those 2 oral upfront combination therapy in addition to just going to a prostacyclin if they're high risk, which is either IV or subcutaneous, epoprostenol or treprostinil. And this is based on, let me talk a little bit about the data that this is based on. So those for dual oral upfront combination therapy, you can refer to the Ambition trial. It tested that study looked at the combination of ambrisentan and tadalafil, and there was a reduction in the time to clinical worsening. In these patients, the Triton study looked at macitentan, tadalafil, and then selexipag for oral therapies. It reduced the pulmonary vascular resistance, a reduction in cardiac biomarkers, and patients had an increased 6-minute walk distance. And then ADUI looked at the combination of macitentan and tadalafil, and patients had a reduction in pulmonary vascular resistance and an increase in 6-minute walk distance. And really what influences our decision to treat high-risk patients with dual oral therapy in addition to prostacyclin therapy are influenced by well-conducted observational studies with triple therapy, and then expert consensus recommendations. Okay, step 3, then we're going to do a follow-up risk assessment. When do we do that? So experts in general recommend, we see patients every 3 to 4 months. They come back into clinic after starting medical therapy. If they've been, reasonable to keep as an outpatient and are doing okay, we have them come back in. We do a follow-up risk assessment. Again, for me, the Reveal Lite 2 risk calculator, and then we determine their risk at that point. Now, here we're going to not just stratify into ongoing high risk versus not, but we're going to further kind of have a little more of a granular categorization of them. So step 4, we're going to classify them into low, intermediate high, or high risk patients at their 3 to 4 month follow-up visit. Okay, so let's start here with the red star. What if we see our patient, she follows up, we get an intermediate low risk score on our Reveal Lite 2. At that point in time, you have a few things to choose from. We can add Sotatercept, which more data is coming out on Sotatercept. So these recommendations may look different at our next, World Symposium of Pulmonary Hypertension, or as experts get together and review the data. But Sotatercept, we have oral and inhaled prostacyclins. And we have soluble guanylate cyclase stimulators. So we'll talk about that on the next slide. After we review the different options and why we might choose one over the other for intermediate low risk, we'll talk about patients who are intermediate high risk. High risk patients, we're going to add Sotatercept to those patients if they're already on a PDE5 endothelin receptor antagonist and IV or sub-Q prostacyclin, we're adding Sotatercept. And we'll talk a little bit about the Zenith trial results that were just presented at the ACC. And then going back to the other end, if they're low risk on follow-up assessment, we're going to continue their initial treatment. So ideally, let's say our patient follows up, they're low risk, continue treatment. They're high risk, we're adding Sotatercept. They're somewhere in the middle, we're making a different decision based on intermediate low or intermediate high risk. Okay, so here are the different options we talked about for that intermediate low risk group. We've got oral prostacyclin, selexipag, oral treprostinil, Orenitram is the brand name. We have activin signaling inhibitors now, Sotatercept, inhaled prostacyclins, inhaled treprostinil, also Tyvaso is the brand name for that, and then soluble guanylate cyclase stimulators, or riociguat. Adempas is the brand name for that. So kind of some data that are for oral prostacyclins. They were studied. Those studies involved a relatively large number of patients. a lot of patients, when they added selexipag, at least not necessarily oral treprostinil, a lot of patients were already on some background therapy. I say a lot, about a third were on 2 oral therapies in the Griffin trial. It reduced time to clinical worsening, and there's long-term safety data, which makes everybody feel better. The cons, there was just a modest increase in 6-minute walk distance. Patients tended to have a fair amount of side effects related to the oral prostacyclins that we see with IV, diarrhea, nausea, a lot of GI symptoms. And then the treprostinil, just a word about that, it was added to monotherapy in the trials and not the 2 oral background therapies like selexipag. Moving on to Sotatercept, it was studied in a large number of patients. Those patients that were either on 2 to 3 drugs, 96% of them, there was a substantial increase in 6-minute walk distance compared to the oral prostacyclins. There was a reduction in pulmonary vascular resistance, and many secondary endpoints, including cardiac biomarkers and NT-proBNP, were improved. The con for Sotatercept is it has some interesting side effects, epistaxis, erythrocytosis, thrombocytopenia, telangiectasia formation. So it has some odd, interesting side effects based on the mechanism of action. And then there's shorter term safety data as compared to the oral prostacyclin drugs. Inhaled prostacyclin treprostinil, we know in patients it increased 6-minute walk distance, it improved quality of life. The con was that it was studied in patients who were on monotherapy, and it's just less convenient to take, makes people cough. You have to do it 4 times a day. And then riociguat, the soluble guanylate cyclase stimulator, patients, it's probably just a stronger, drug that increases the availability of nitric oxide. You would substitute tadalafil, sildenafil, your PDE5 inhibitors for this. You don't use them together. There was a study that showed clinical improvement in these patients, but it was an unblinded randomized clinical trial. So bringing this home, what patient might I choose to use each of these in? Well, I would use maybe oral selexipag or treprostinil in patients who have a higher bleeding risk. So maybe Sotatercept is less ideal. If we feel like we need more comfort with longer term safety data, or patients uncomfortable taking something like Sotatercept for that reason, and we're aiming to reduce time to clinical worsening for that patient, I might consider Sotatercept much earlier on, especially based on the data that's coming out, but in patients who have a higher symptom burden or poor exercise tolerance, because they did much better with Sotatercept. They walked further, they felt better than the oral prostacyclin drugs that we have. I might do an inhaled treprostinil in a patient that I have tolerability or side effect concerns with the other medications, Sotatercept, and then really nausea, vomiting, diarrhea with oral Sotatercept. And the patient just really can't tolerate that, but I need to add something to their pH treatment regimen. And then in patients who are riociguat, unwilling to take additional medications, we kind of throw that out. So we substitute one with the other. Maybe it's a little more effective. We did have a trial, though it was unblinded randomized clinical trial that showed an improvement in, time to clinical worsening. So take that with a grain of salt. Okay, so now we're going to move on to the red star over here. So that was intermediate low, several different options, when I might use them, a brief review of the data. The intermediate high risk population, we're adding Sotatercept, probably, or IV subcutaneous prostacyclin, intermediate high. High risk, if presumably they're already on IV or subcutaneous prostacyclin, we're adding Sotatercept. So let's talk about the current status of Sotatercept for a minute. The Soteria trial is an open label long-term follow-up from the parent trial that's ongoing. There's the Hyperion trial, which patients were on a background of dual oral therapy. They were functional class 2 to 3, so sick but not the sickest. And the Reveal Light 2 score was 6+, which put them basically at an intermediate high risk score. This was recently stopped early due to the results of Stellar and the Zenith trial that was just published due to loss of clinical equipoise because of the benefit of Sotatercept. So the Zenith trial, patients were on dual or triple therapy. I believe 60% were on IV therapy. They were pretty sick. They were sick. Their functional class was 3 to 4, and their Reveal Light 2 was high risk, 9+. This trial was just published and stopped early due to efficacy presented at the ACC. And there was a significant difference in the primary endpoint of all-cause death, lung transplant, and hospitalization. If I remember correctly, there was a difference in hospitalization between 50% in the placebo group and like 9% in the Sotatercept group. So really impressive results. Okay, so let's follow up that initial case. Her initial reveal light 2 risk score was 6, so she was intermediate risk, not high risk. So we started her on upfront macitentan and tadalafil. She had a follow-up assessment with us in clinic 3 months later where she had improved functional and exercise capacity. We felt better. Her echo showed a smaller RA and RV. Her reveal light 2 risk score at that time was 4, technically low risk. And so we continued her on her current medications with a plan to follow up 3 to 4 months later. Okay, so a summary of group 1 PAH, take a risk-based approach. So step 1, initial risk assessment. Are they high or are they not high risk? Okay, you do your treatments based on that. Step 2, they're following up. You're initiating treatment based on the first risk assessment. Step 3, you're reassessing that risk 3 to 4 months later. Step 4, you're augmenting treatment based on their follow-up risk assessment. Don't forget to incorporate hemodynamics and RV imaging into decision-making, and then personalized treatment based on patient characteristics and wishes. Lots of risk-benefit discussions and patient-centered approaches. Where we get into trouble sometimes with functional class is in our patients who are younger. So they can be pretty sick, but we may not capture that in their 6-minute walk distance per se, because they're able to compensate. So we take into account other factors. On the other spectrum, we have older patients who may have a little pulmonary hypertension, but their risk score is going to look worse because they can't walk far. Maybe they have arthritis, osteoarthritis. They have other comorbidities that really would influence their score, but might not be particularly related to pulmonary hypertension. So taking everything into account here. Okay, let's switch gears and talk about group 2 PH due to left heart disease, which all of us in advanced heart failure transplant are absolutely going to see, especially in our high-risk patient population. Why should you care about PH, group 2 PH? It's super relevant to all of your clinical practices. It's the most common cause of PH. Up to 60% of patients with systolic dysfunction will have concomitant pulmonary hypertension, and up to 80% of those patients who have diastolic dysfunction or HFpEF. PH is thought of as a complication or a symptom of LV dysfunction, whether that's HFrEF or HFpEF. Patients with concomitant PH have more severe heart failure symptoms, worse exercise tolerance, and their outcomes are impacted. You have a worse outcome with pulmonary hypertension, even if it's passive, than you do without pulmonary hypertension in your patients. Just briefly, everybody can come back to this and look at the data and look at the calculations, but passive PH due to left heart disease really is going to be backstream pressure, right? So it's all due to elevated left-sided filling pressures that transmits back into the lungs and to the right side of the heart. A reminder how to calculate transpulmonary gradient, your mean PA pressure minus your wedge pressure. Normal is less than 12, I say 12 to 15-ish. Your pulmonary vascular resistance is that transpulmonary gradient over your cardiac output. Normal is, for purposes of treatment, used to be less than 3. Again, less than 2 is actually technically normal now that we have more data. And then diastolic pulmonary gradient, that we don't really use clinically so much anymore, just to be aware of as a metric, is diastolic PA pressure minus your wedge, and normal is considered less than 7. If you have mixed PH due to left heart disease, really you've had this thought to have this backward pressure for probably long enough, and perhaps a component of genetic influence that causes pulmonary vascular remodeling in the pulmonary arteries here. So these patients will have a wedge that's elevated, a transpulmonary gradient that's elevated, and a pulmonary vascular resistance that's elevated. So this is your mixed combined pre and post capillary pulmonary hypertension that we talked about in the initial definition. And we actually see this. So these are people who either went to heart-lung transplant. It would have been heart-lung transplant or passed away, because they have clearly cross-sections of their lung tissue here, and we're looking at their pulmonary vasculature. But we know that these actually do reflect underlying pulmonary vascular remodeling. So you can see in the tissue sections on the left-hand column here, the transpulmonary gradient is low, 3, and you have nice thin pulmonary arteries. In a patient that starts to have upper limits of normal, maybe, or a little bit high transpulmonary gradient, the walls are thicker. And then you have someone with a transpulmonary gradient from heart failure with mixed PH who has a TPG of 30, a diastolic pulmonary gradient of 13. And look how thick that wall is. And this is compared to idiopathic PH here. It looks pretty similar. this is showing the same thing here. Those who have elevated metrics of figuring out pulmonary vascular remodeling or pulmonary arterial remodeling, thicker walls here than you do in a patient who didn't have pulmonary hypertension. Okay, what about pH-specific therapies? And we just have a couple more minutes left here. pH-specific therapies in our patients with mixed pre- and post-capillary pulmonary hypertension. So this chart here, I'll let you guys come back to that and take a look. But in general, our patients, we've had patients with heart failure, both HFpEF and HFrEF, that we've studied PH pulmonary vasodilator therapies in. And in general, although some smaller studies may show improved exercise performance, maybe some improved hemodynamics, the larger studies have really shown no benefit. And we've had several studies as of late that have actually probably shown they're signal toward harm, or they've showed worsening heart failure. So I'm going to focus on that here. I want to bring your attention to the PASSION trial, which was published recently. This was a HFpEF population and patients who had HFpEF and pulmonary hypertension. They had to have invasive hemodynamics and their PVR was greater than 3. We looked at even just tadalafil, just a PDE5 inhibitor versus placebo. And this study was actually terminated early due to supply, but there was a signal of harm in patients who actually in patients who received tadalafil versus placebo. So this influences our decisions. I feel like historically everybody used to sprinkle a little PDE5 inhibitor on these patients and think it probably doesn't hurt, maybe it helps, but maybe we're wrong about that with the latest data that we have. The Serenade trial was also published relatively recently, looked at macitentan and endothelin receptor antagonist versus placebo. It looked at patients who had heart failure with mildly reduced EF or HFpEF. Their PVR they had some evidence of pulmonary hypertension. They could have a PVR greater than 3, an RVSP greater than 40, or a mean PA pressure greater than 25 on invasive hemodynamics. And this drug did not lower NT-proBNP or improve heart failure outcomes at all. The Melody 1 trial looked at macitentan versus placebo in patients with mixed PH and HF. So we just saw Serenade, Massey, in HFpEF patients with PH, and now we're looking at mixed PH. Now we're looking at macitentan and HFrEF with mixed PH, worse fluid retention, no improvement in hemodynamics or NT-proBNP. And then the Cyovac trial looked at patients who had valvular heart disease associated mixed PH. They had their valve fixed at least a year before, and they had persistent PH despite fixing the valve. They were put on sildenafil versus placebo, and they had worse outcomes in those who received sildenafil, worsening heart failure hospitalizations. So really, we actually don't have pulmonary vasodilator therapy that's indicated in this patient population, unfortunately. So PDE5 inhibitor, it's probably not helpful, right? It's probably a little harmful based on the data that we just discussed. Endothelin receptor antagonists clearly result in fluid retention, and prostacyclins in the first trial up here at the top actually were studied in patients with HFrEF. They didn't have to have concomitant PH, and there was a decreased survival in that patient population. So lastly, a couple slides on the role of vasodilator testing, and then one slide on CTEPH. Vasodilator testing identifies a group at high risk for transplant. So here are patients who have HFrEF, and they have pulmonary hypertension on their right heart cath for their assessment for transplant. If these patients were then stratified based on what their PVR was and their response to a trial of nitroprusside. So this study still influences our guidelines. It was published in the early 1990s, and it was out of Stanford. So these patients got a heart cath. If they had significant PH with a PVR that was greater than 2.5, they got nitroprusside infusion, and we took a look at how they responded to that. Did their PVR lower below 2.5, and what did their blood pressure do? And then their outcome post-transplant was basically evaluated. So in patients who had an initial right heart cath, we're going to start over here. If their baseline PVR was less than 2.5, they didn't get nitroprusside, their kind of 3-month mortality is about 7%. Okay, so we're calling that kind of our, placebo or control group. In patients who had a PVR greater than 2.5, that's who we're going to talk about in the other 3 columns. They got nitroprusside. If we could lower their PVR to less than 2.5 without the expense of hypotension, meaning their systolic blood pressure maintained above 85, their risk of 3-month mortality was only 4%. So not too far from our kind of control or placebo group. So those patients who had reversible pulmonary hypertension without systemic hypotension did pretty well for after their 3 months after transplant. If we had patients that had a PVR greater than 2.5, we gave IV nitroprusside. Their PVR we could lower, but only at the expense of hypotension. They actually had a 28% 3-month mortality. That's pretty high. And the orange here versus the blue is kind of death thought attributed just to right heart failure or PH and death due to other causes. So this isn't necessarily, they're not all dying from PH-RV failure. It's just probably a marker of how sick these patients are and their other comorbidities that influence pulmonary hypertension. And if we couldn't reverse the PVR stayed above 2.5 despite a nitroprusside infusion, these patients had a 40% 3-month mortality. So roll for vasodilator testing. And just to give you a little bit of an algorithm, if you have PH from left heart failure on GDMT as much as they could tolerate and they're transplant eligible, you should perform vasoreactivity testing if these patients have a PVR greater than 3 or a transpulmonary gradient greater than 15. If they're vasoreactive, we saw the data on probably safe to proceed to transplant. If they're not vasoreactive, then what the guidelines recommend is aggressive pharmacologic treatment, give them mechanical circulatory support or combination treatment. Get their wedge down, keep it lower, put them on inotropes. Maybe they need to be unloaded with an Impella or some other type of form of mechanical support. And you may need to give them some time and park them in the ICU with a Swan Ganz catheter in place and titration of vasoactive therapy is depending on the patient profile. If they have persistent PH despite 48, 72 hours in the ICU of inotropes, vasodilators, mechanical support, then the recommendation is to proceed to LVAD therapy at that point in time if PH is prohibitive for heart transplant. Or you can consider them for heart-lung transplant. And of course, if they improve, their risk is lower and it's probably okay to proceed to heart transplant depending on the situation. Okay, so in summary, group 2, understand passive versus mixed PH. Vasodilator testing is recommended for patients with advanced heart failure undergoing transplant evaluation if significant PH is present. And there's no clear benefit, as we saw, to medications used in group 1 PAH in this patient population with mixed PH due to left heart disease. There's more emerging evidence for harm, as we saw. And last slide here, two slides, CTEPH. So chronic thromboembolic PH. The curative treatment really is pulmonary thromboendarterectomy surgery. So if a patient has surgically accessible disease, they should be sent for pulmonary thromboendarterectomy surgery. Balloon pulmonary arterioplasty is an alternative if they're not a surgical candidate. So oftentimes these are patients who have very distal chronic thromboembolic disease that we can't get from a median sternotomy and a proximal kind of retraction of their central disease if they have distal disease. And then if they have inoperable CTEPH, there is data to support the use of riociguat, our soluble guanylate cyclase stimulator. So this is from the World Symposium on PH, most updated guidelines that came out later in the fall of 2024. If a patient has a CTEPH diagnosis, they should have lifelong full anticoagulation. They should be referred to a CTEPH center for multidisciplinary team approach. If they're felt to have operable disease, it's recommended to go to pulmonary endarterectomy. If it's not operable, consider them for balloon pulmonary angioplasty for symptom relief. If they're a candidate for that, then we pursue balloon pulmonary angioplasty. If they're not, then the recommendation is to place them on riociguat. And then we evaluate them in 3 to 6 month intervals or so for improvement in their pH. Okay, that is all I have for you guys. Sorry, we went a tiny bit over in time, but hopefully that was helpful, and I'm happy to answer any questions, and feel free to send me an email at any time if I can help clarify anything.
Do you have any questions out there from the group for Dr. Hardin? I've just had one question for you, Ashley. What do you think's going on in these patients when as you mentioned, parking them in the CICU and putting them on some temporary mechanical circulatory support or inotropic support? What do you think's going on in their pathway physiologically that's then allowing them to become transplant eligible?
Yeah, that's a great question. I think a lot of these patients probably just are chronically not unloaded. So I think if you can demonstrate that you can reverse their pH in a short period of time, even if they're not acutely vasoreactive, I think we just need to show that if we give them a new heart, their cardiac output is relatively normal, and we lower their afterload and improve their filling pressures. If we can do that within a relatively short period of time, they probably have some component of vasoreact. They have some component of reversible pH. And that's really what we're looking for, is they don't have such significant ongoing elevation in their pulmonary vascular disease that when we transplant them, of course, they're going to have severe RV dysfunction and primary graft dysfunction, et cetera. I think what's going on and why our other pulmonary vasodilator therapies don't work is that there are some pathology studies that look at these mixed pH patients, and they tend to have a lot of pulmonary venous remodeling, probably because their pulmonary wedge is elevated chronically. So they then behave more like a pulmonary veno-occlusive disease type patient. They just tend not to benefit from pulmonary vasodilator therapy. It's probably just either over time, or there is an overlap if you look at certain SNPs in those patients who have PAH versus group 2 PH with mixed pulmonary vasculature. There are some SNPs that are shared. It's like, who has a wedge that's 30 for 5 years and doesn't develop PH versus does? It's not necessarily a guarantee, but we see a lot of patients in that context. So I think that those are generally the patients that I see. They either sit with a high SVR and elevated left-sided filling pressures that they just need a little time to show us it'll come down. Hope that answers it. It's a little long-winded.
Yeah, no, that was good. Yeah, no, it was good. And then one last question for you.
Yeah.
So let's say, I inherit a patient that is on sildenafil or tadalafil, and have been reasonably stable on the drug. This could be a HFpEF patient. This could be a patient after transplant who, was put on the drug before transplant as a thought that they needed to be on some form of therapy because their PVR was a little high.
Yep.
If people are reasonably stable, do you recommend just leaving it alone, or based upon that data, do you think that would be an error because you are possibly putting them at risk for harm and we should just take it off?
Yeah, I mean, I think that I don't start them anymore like we might have used to. So that's one thing. I'm not starting. If they've been on it, we still are seeing people either after VAD or after transplant on PDE5 inhibitors. And what I'll do is I'll just obtain another set of hemodynamics. And if that's something that we've modified, right? In those patients, we either transplanted them. So now hopefully their wedge is good and their cardiac output's normal. I'll take them off of that if after repeating hemodynamics. If they're, with both a post-VAD or post-transplant. I think if they're reasonably stable and there's not a drug-drug interaction, I think it's reasonable to watch them on it. And if they do poorly, take them off of it, like they're having worsening heart failure symptoms, volume overload. But I certainly wouldn't start it at this point. And after our post-VAD transplant patients, I try and take it off. It's a good question. And some people have connective tissue disease, right? They have scleroderma and they have HFpEF. And so it's a really fine balance. We know that, it's what's kind of driving their symptoms and doing a stepwise introduction of medications, because as the population is aging and we're doing better at helping people live with chronic conditions, we see just obviously a ton of really mixed patients. They're not always clear cut. And so we'll actually probably not do maybe dual oral upfront therapies in those who have HFpEF or have a risk for HFpEF, but they have something else that they have some pH out of proportion to left heart disease, and they have like scleroderma, for example. So we may put them on a PDE5 or 5 inhibitor, watch them for a period of time, make sure they're doing okay before adding that next step. So with comorbidities, you kind of start low and go slow.
All right. Well, thank you so much. Appreciate the talk, and thanks everybody for joining. Have a great rest of your week.
Thanks for joining.
Bye-bye.
See you guys.